Hello, my name is Dr. Shanda Blackman, and I'm a cardiothoracic surgeon trained at Baylor College of Medicine. I'm currently the Executive Director of the Baylor College of Medicine Lung Institute and the Olga Keith Weiss Endowed Chair in Surgery. I'm a professor of surgery within the David J. Sugarbaker Division of Thoracic Surgery and within the Michael E. DeBakey Department of Surgery. Today I'd like to present to you salvage, revisions, repairs, and replacement, complex esophageal intervention. We'll be discussing approaches and strategy. I have no relevant disclosures except for I have IIT-funded clinical trials from Natera, Medtronic, and Steris. I'm on the AstraZeneca Advisory Board, the Ethicon Advisory Board, and I have co-developed instruments for minimally invasive thoracic surgery with Scanlon Instrument Development Company, as well as I am the app developer for the Upper Digestive Disease app that was developed concurrently with Mayo Clinic. I also hold several United States patents, and I'm the author of the support group and the Atlas of Esophageal Intervention by Springer. The outline for this talk includes a discussion about salvage, including stenting, vacuum therapy, internal and external plication, dilations, assisted emptying, untwisting, operative revision, and endoluminal repair. We'll then discuss replacements, including routes, timing, and conduits. We'll discuss re-replacement and repair approaches, and then we'll have a brief discussion about tracheo-esophageal fistulas. First, we'll begin with salvage. The tenets of safe stenting of the esophagus include using on-label stents. Whenever an off-label stent is being acquired and used for a procedure, an IDE with the FDA should be indicated and applied. It is specifically important to make sure that devices or implants are not used like the Amplatzer, which is essentially a foreign body. By putting in devices that create a foreign body reaction, it is unlikely that these will result in closure of an esophageal fistula. In spite of this being widely known, today I still see many circumstances where an Amplatzer device is misused and deployed for tracheoesophageal fistula or other procedures. All leaks must be drained. Stents must be repositioned at least every 3 to 4 weeks to prevent migration and to prevent erosion from radial force at the flare, causing the stent to erode into adjacent structures like lung or aorta. Stents should be sutured into place to prevent migration, especially when fully covered stents are being used, as these will be very unlikely to grow and anchor over time. Also, placing muscle or tissue between the fistula areas to separate organs and structures will enhance wound healing as the stents are deployed. These are referred to as hybrid procedures. We should manage the stents with a stent diet, meaning nothing too hot to melt the silicone and nothing too cold that would cause the nitinol to shrink and the stent to migrate. An aspiration protocol should always be employed with elevation of the head of the bed at all times for patients where the esophagogastric junction is stented and pried open. This makes patients extraordinarily prone to massive reflux events and aspiration. And imaging should always be employed to check the position and placement of the stent. Optimize nutrition while healing, which will enhance closure of any fistulas or closure of any leaks. Salvage. It's important to review the literature for stenting. In the early days of esophageal stenting in the early 2000s, we started to deploy the stents through an IDE with the FDA, not sure whether or not we needed fully covered or partially covered, what length was required, what happened when we stented across the esophagogastric junction, what happened if we clipped those into position with a resolution clip versus sutured them into place with the Apollo device. And over time, we've learned all of these tenets that I've shown to you today. It is with excruciating detail that we have analyzed each of these cases and reported them that we are able to make these statements today. So what if you perform a minimally invasive esophagectomy and you pull up a gastric conduit and the conduit is in fact too short? You basically have a choice that you can make in that circumstance. When the gastric conduit is too short, you can decide if you want to immediately reconstruct with a new conduit that you had not prepared or planned for, or you can delay reconstruction. In almost all of these cases, I prefer delaying reconstruction so that you can gather the appropriate team, make sure the patient is nutritionally optimized, and not be performing a complex procedure at the end of a day when most team members are not at their best. Some principles of vac therapy for the esophagus. Again, just as we talked about in stenting, all leaks must be drained. The advantage of using a vac is that it can be drained internally. You should reposition the vac every 4 to 6 days, suture or bridle drains in to prevent migration, place muscle or tissue between other structures like the trachea, bronchi, or aorta, and manage with distal feeding. Optimize nutrition while healing. In this particular circumstance, I prefer to use a vac sponge on the tip of a 60 centimeter long pigtail drain that can be placed through the nose and anchored into position and sutured externally or bridled externally. Bridling prevents a wound to be occurring at the nair where a suture might be too tight and cause necrosis. It is always important to make sure that when you are deploying the 60 centimeter pigtail catheter with the vac sponge at the tip, that you control the amount of suction that's being placed and that it should be placed deep inside the cavity so that the vacuum suction can take effect. Others prefer a nasogastric tube as the delivery device for the vac sponge. And still others have found the benefit of covering that vac sponge with the tip of a glove, which prevents the vac sponge from becoming too incorporated into the adjacent tissues. When the esophagus has a leak and the vac sponge is placed into the cavity of the leak, you can develop a regeneration problem. And this is widely published by Cornelius and colleagues. A thin-walled glove with micro deformation permits suction being performed without having the sponge become too incorporated into the tissue and puts you at less of a risk for bleeding. Do not place a vac if the leak is in direct opposition with the airway, which is an esophagobronchial fistula, or if it is in direct opposition with the aorta, which is an esophago-aortic fistula, or if the cavity has exposed raw lung surface or exposed aorta. Any type of exposed organ that can be seen when you scope into the leak is at risk for forming a connection that can be abnormal. Also, it is possible to place a vac sponge and then over the vac sponge to place a stent. But remember, there may be sealing issues at the proximal extent of this stent where the catheter is placed that extends to the sponge. Additionally, if patients have prolonged stenting required or prolonged feeding tube required or prolonged vac sponge deployment required, we prefer to use an ultrasound probe to avoid the carotid and jugular vessels and then to place a Kittner at the tip of the left side of the pharynx and to place a pharyngostomy tube, pulling the tube out of the mouth initially, as seen in the third image, and then directing it down into the esophagus. Although this does create a tiny perforation in the pharynx, this quickly heals and can provide enhanced comfort for the patient as they have prolonged tube placement during this time. It is much more comfortable than having it go through the nose. This is a particular patient that required a hybrid procedure to control and treat an uncontrolled leak. In this particular patient, we performed operative operative intervention to interpose muscle in between the esophagus and the outer lining. Extensive contamination of the esophagus when it's perforated requires video-assisted thoracoscopic or robotic or open drainage. Empyema tubing can also be placed, and then the drains can be slowly withdrawn after 48 hours of suction. The image at the bottom shows what you can perform as far as a muscle flap when the patient no longer has viable latissimus or serratus muscle flaps, when their source vessels have been destroyed, perhaps when the patient has had a prior open thoracotomy. This is what we term as a freestyle flap that uses the chest wall with the blood vessel from the intercostal muscle and rotates it through the space in between the ribs and is used to buttress against a leak. This can also be used to close tracheo-esophageal fistulas when an intercostal muscle is not a viable option and latissimus or serratus are not viable options. Alternative options include gastroepiploic-based omental flaps, free flaps, and VRAM flaps or pectoralis flaps. Patients present with end-stage achalasia and have what is characterized as a megaesophagus with sump formation. Patients who present with a megaesophagus and sump formation are frequently offered esophagectomy. However, it never made sense to me why we performed esophagectomy, replacing one bag of the esophagus with the bag of an aperistaltic gastric conduit. And it is for these reasons that I came up with the concept of plicating the esophagus to reduce redundancy and give the patient an improved swallow over time. I first published this many years ago when I was present at Mayo Clinic, and we performed one of the first per-oral plications of the esophagus after we discussed this in a multidisciplinary meeting. It never occurred to me why patients would really benefit from an esophagectomy, which is an inherently morbid procedure, any more than plication of the esophagus. The disadvantage of plicating the esophagus, however, is that it may require repeat intervention on a yearly basis, as eventually the plication will come undone. However, if it were me, I would much rather have a yearly plication of my esophagus rather than all of my anatomy revised and moved around and have to undergo an esophagectomy. This esophageal preservation approach is a unique approach and requires a skilled endoscopist, whether it be a surgeon or gastroenterologist. Getting rid of the sump by plicating the esophagus and making the esophagus overall more narrow with either one or two plication events can help the patient to facilitate a more efficient swallow. It is important that before the patient is offered a POPE procedure or per-oral plication of the esophagus, that they first make sure that these patients have undergone some type of treatment of the lower esophageal sphincter to facilitate emptying, whether it be a POEM procedure, per-oral endoscopic myotomy, or whether it be a laparoscopic modified Heller myotomy or robotic modified Heller myotomy. Regardless of the way that the lower esophageal sphincter is released, once it has demonstrated appropriate release, it can then be plicated to create a more efficient emptying. This video was first presented at the General Thoracic Surgery Club in 2019 in Naples. As you can see in this particular case in our publication, as well as in the video of videogie.org, the patient had an angulated esophagogastric junction and severe sump formation. After plication, that sump formation was gone and the esophagus was more narrowed and there was no more bezoar or food retention within the esophagus. This video demonstrates the technique that we developed. We have performed this in patients who have a colon interposition after esophagectomy and in patients with megaesophagus. Here you can see initially the scope is performed with the presence of a megaesophagus. Argon plasma coagulation marking is performed to show the area that will be plicated for in the future and reducing the lumen. As you can see, we'll be excluding a huge amount of the esophagus, and in this particular circumstance, we decided that we would need to perform the esophagoplasty with multiple layers or plications. This cartoon shows how the endoluminal Apollo endoluminal suturing device takes and tacks and plicates the internal lumen of the esophagus, just as we perform smocking for clothing. A figure 8 type fashion is used as it is sequentially folded up and the esophageal lumen is narrowed. In this particular case, you can see the anchoring device of the Apollo is screwed into the tissue to bring the tissue and deliver it into the jaws of the suture that's passed. After the suture is passed through the first area, the anchor is released and redeployment of the anchor into the next area that is to be sutured is performed. 3 areas go across in a horizontal fashion before the second layer of the figure 8 in a parallel horizontal line just above the first line is performed. As you can see, the endoluminal device easily passes through the esophageal tissue. You can make a decision about how deeply you want to deploy the anchor and whether or not a full thickness esophageal anchoring is required or just acquiring that layer of the mucosa. In this particular case, the mucosa is grasped primarily, but some layers of the muscle layer of the esophageal wall may also be grasped with this endoluminal suturing. Again, this is important to note that the first development of this technique was developed by my team in 2017. Again, was first presented as a video at the Southern Thoracic Surgical Association and then the General Thoracic Surgery Club, and is used with permission from the Southern Thoracic Surgical Association archives. After multiple deployments of figure 8 endoluminal sutures, you can see the esophageal lumen begins to narrow. Although this procedure has to be repeated on a yearly basis, the relief that patients receive once the plication has been performed is far better than having to undergo an esophagectomy or having to undergo the presence and continued fermentation by having food collect within the stump of the megaesophagus. Once again, the anchoring device is passed in after the final suture is released. Here we see the next anchoring device going into the tissue and then releasing the tissue after another row of plication is performed. This plication technique is used over and over again until finally the esophagus is more narrowed, more straight, the sump is gone, and there is no remaining area of massive dilation. The next area of salvage is internal plication or external plication. Some patients present with a congenital esophageal atresia after having undergone a colon interposition and have redundancy with distal obstruction. In this particular patient, he presented with a massive distal stricture at the bottom part of where his colon interposition joined the stomach. And in this case, we performed laparoscopic transgastric stapling to augment the cologastric anastomotic stricture. We placed the laparoscopic stapler through an abdominal port that was placed through the abdominal wall and into the lumen of the stomach. This was a balloon-tipped port and was used to anchor the stomach wall up against the abdominal wall, giving us free access with one angle of the stapler going into the lumen of the strictured cologastric anastomosis into the colon, heading towards more proximal direction, and the other part of the stapler going into the cardia of the stomach. This two-pronged approach allowed deployment of the stapler, which opened up the stricture and concurrently got rid of that narrowed portion of the new cologastric anastomosis, which was now wider and easily seen with fluoroscopy. This post-surgical revision of anastomotic stricture is a novel approach that requires less surgery, less dissection, and a peg was then placed into the area where we entered the stomach. Endoscopic guidance and laparoscopic guidance was used. However, laparoscopic visualization of the area was very difficult due to the severe scar tissue in the area. External plication can also be performed. This is a patient who was referred to me who had a congenital esophageal atresia. She had a full stomach pulled up into her thoracic cavity and anastomosed to the distal esophagus. And it was this full stomach that continued to form a sump, collect food, create bezoars, and poorly empty. As can be seen in the publication on the top right with the illustration, endoscopic plication can provide relief in some circumstances. However, when we performed endoscopic plication for this patient, she received no benefit, and thus we performed a laparoscopic conversion to open right redo thoracotomy with external plication and straightening of the sump. In the image to the left, preoperatively, you can see the S-curve with the severe stump, and in the image to the right, you can see there is no longer a stricture where the full stomach is going down into the pylorus because Botox has been injected. Thus, the gastric emptying has been facilitated, as well as a more straightened gastric diameter where the gastric conduit is no longer with a sump formation and has a more narrowed appearance from the external plication. Other salvage revisions can be seen here with this same patient. The external plication to revise the conduit was performed for this patient with esophageal atresia who had the whole stomach used to replace the esophagus as a child. The preoperative image is seen to the left and the postoperative image is seen to the right with a more straightened and narrowed conduit. Other salvage techniques and procedures can include stenting for any type of stricture. However, it is important that thin-walled strictures can also erode into adjacent structures. Caustic ingestion patients who have anastomotic strictures, patients who have severe dysphagia may benefit from a procedure called self-dilation. Self-dilation videos are available on YouTube, but involve bougie dilators that are heavily lubricated and the patient is taught to swallow. Serial balloon-tipped dilation is performed until the patient has an internal diameter of at least 12 millimeters. Once the patient has an adequate diameter, a straight esophagus, a straight distal conduit, and is deemed to be appropriate for self-dilation, self-dilation can be taught. The patient is basically taught to wake up in the morning, brush their teeth, lubricate the bougie dilator, swallow and self-dilate, and then remove the bougie, clean it and wash it in the sink, and then go on about their day. Untwisting can also be required. In this particular patient, they were referred to me with a twisted colon interposition. This twisted colon interposition required untwisting in order for salvage. It is necessary to be able to identify endoscopic twisting of the mucosa, which appears like a swirl when endoscopy is performed, and esophagram will demonstrate narrowing and poor emptying. Untwisting an interposed colon can be quite difficult, but following the Taenia coli can help to guide you. It is important to always provide continued blood supply and make sure that you do not interrupt the mesenteric blood supply of a colon interposition, or it would become necrotic. In this particular instance, we merely transected the colon, untwisted it, performed a stapled side-to-side functional end-to-end anastomosis, and allowed the blood supply to go behind that new interposed untwisted colon. This is a novel procedure that allowed the patient to not have to have another novel conduit created and salvaged a suboptimal colon interposition. Operative revision of conduits can sometimes be required for reducing a redundant conduit herniation, as is widely published in the Lukatich series. In this particular case, the patient had distal obstruction and required release of the diaphragm, reduction of a redundant gastric conduit, and sometimes requires untwisting, straightening, narrowing, or plication. Salvage can also be required when a paraconduit hernia occurs, whether it be the conduit itself that herniates up, as is seen in the image to the right, or when other structures such as colon herniate up alongside the conduit, as is seen on the left. Operative revision of conduits is published in the Annals of Thoracic Surgery by our team, including Dr. Carlos Puig and I. The laparoscopic approach with instruments placed can be seen in the image to the right, and the procedure can be seen in the image to the left. In the first portion of the procedure, we identify that the anastomosis is widely patent. A gastric conduit is pulled above the level of the azygous vein, and in this circumstance, first we make sure that there is no twisting of the conduit by following the staple line, either laparoscopically or thoracoscopically, or by looking at it on the imaging with the preoperative CT scan. In the image to the left, you can see the conduit has herniated and caused redundancy, as in figure B in the top middle. In figure 2B on the top right, you can see a paraconduit hernia of colon that has gone up alongside the conduit. In this circumstance, a gastric conduit is drawn. The first goal of repairing a paraconduit hernia is to reduce all of the adjacent structures as well as the conduit itself to create a narrowed straight conduit, and then to perform a fundoplication like imbrication of the conduit at its widest portion to imbricate in the blood supply so that the conduit can be 360-degree tacked all the way around to the crural fibers on the inside. The transection of this for purposes of visualization can be seen in the bottom right images. It is important to note that if a very thin conduit has been created, it may not be possible to imbricate the blood supply and perform a 360 plication. But in that circumstance, one must be wary that sometimes the paraconduit hernia can recur if there is an area that is left untacked. The crural fibers should be reapproximated to close the opening narrowly against the stomach, but to make sure that it is not narrowing or causing compression so that the stomach cannot empty. Untwisting can be seen again in this illustration, where a patient had undergone a minimally invasive esophagectomy, and when we followed the staple line on the CT scan, we could see that it twisted around clockwise. This patient was treated with a video-assisted thoracoscopic combined laparoscopic revision. We transected the distal conduit and placed a roux going up to the terminal end of the gastric conduit to facilitate emptying. This roux anastomosis is done much like a bariatric gastric bypass procedure and has the additional advantage of using a 50 to 60 centimeter limb to prevent reflux, which is one of the most terrible problems and frequently may help patients who have terrible biliary gastric reflux. Today, very few surgeons who perform minimally invasive esophagectomy cut and divide the pylorus. Most people undergo pyloric temporary paralysis with injection of Botox, or no paralysis with Botox and no pyloromyotomy. By omitting the pyloromyotomy, the theory is that less biliary reflux will occur. There is a small proportion of patients who may require later treatment of the pylorus if they develop a hypertensive pylorus that impairs the emptying of the gastric conduit and starts to make the conduit look like achalasia, where it's dilated and aperistaltic and there is poor emptying at the bottom. These patients always have to be observed with endoscopy and timed barium emptying studies and barium swallows to be able to evaluate the quality and efficacy of the gastric conduit. When poor gastric conduit emptying is identified, a G-POEM or Botox or pyloromyotomy may be performed to relieve any distal obstruction. However, in patients who have florid gastric reflux or florid biliary reflux that is unrelenting, a roux limb can be used to treat that particular situation. In this particular case, the roux limb was used to facilitate distal conduit emptying when the conduit had been accidentally twisted 180 degrees when it was pulled up and the anastomosis was created. Now let's talk about esophageal replacement. In our recent publication in the Annals of Thoracic Surgery this year in 2025, we discussed complex esophageal reconstruction, challenges and techniques. We reviewed a variety of different types and structures, including a gastric conduit, free jejunum and stomach, free jejunum interposed at the level of the cervical esophagus, pedicled jejunum, supercharged pedicled jejunum, colon interposition, including a supercharged colon, and myocutaneous flaps, such as an ALT flap or a radial free forearm flap. Other myocutaneous flaps may include a latissimus myocutaneous flap, where the skin can be folded and stapled to create a tube. We will discuss each of these in this talk. Some of these conduit alternatives that we'll begin with are obviously the ideal conduit, which is stomach. It is based off of the gastroepiploic artery and vein and can be performed in the isoperistaltic direction or can be reversed in the event of a gastroepiploic injury as a reversed gastric tube. Esophageal replacement options always include the gastric conduit as the standard of care in almost all circumstances, whether that conduit is attached to the esophagus in the thoracic cavity or in a cervical anastomosis. It should always be located above the level of the azygos vein, and it should always be aligned in a straight manner and tubularized to be approximately 3.5 to 4 centimeters in diameter. The tubularized gastric conduit is always based off of the gastroepiploic, which is derived from the right gastric coming off of the gastroduodenal. The right gastric comes off and goes anterior and delivers the lower portion of the antrum blood supply to the stomach. There is a lot of debate about whether or not preservation of the right gastric artery results in better vascularization of the gastric conduit or not. However, most of us believe that preservation of the main branch of the right gastric artery does build for a healthier conduit. The right gastroepiploic continues along the greater curvature into the left gastroepiploic, which typically terminates about 2/3 of the way up the wall of the greater curve of the stomach, just inferior to where the short gastrics take place. there is some evidence that preservation of some of those collateral vessels in that small amount of fat can help preserve the distal tip of the gastric conduit when it's pulled up. So how do you maintain and improve a 3-star program for esophagectomy? The answer is, it begins with safety and routine in the operating room, meticulous attention to detail. This is an example of the in-hospital briefing, timeout, debriefing, and post-operative protocol that I use when I'm performing surgical procedures. Before the transportation to the operating room, a briefing is performed in the operating room before the patient comes into the room. This briefing is held always by me, the surgeon. The anesthesiologist is also present in the room along with the circulator and the charge nurse or the scrub nurse. We then discuss the patient name. We verify it. We discuss the procedure to be performed, the site, the positioning, any known issues, NPO status, allergies, airway, intubation protocol, whether it's a single lumen tube or a double lumen tube, whether or not blood consent was verified, and whether or not blood has been acquired or brought into the room, and what our strategy will be for anticoagulation, or what our strategy will be for antibiotic therapy. We review recent labs. We talk about equipment, positioning, any unexpected events. We review where the oxygen shutoff valve is located and always make sure everyone in the room knows where that will be. We discuss with our resident their role and responsibility within the procedure, what portions we expect them to do, what portions we expect to do, and how we will work together throughout the procedure and what the supervision will be like. We also make sure the anesthesiologist has the opportunity to ask about any concerns they may have and verbalize agreement. And then we also review any other concerns that were expressed by the patient or the family. Once the briefing has been performed, we then can bring the patient into the operating room. A briefing note is placed into the chart, and before the skin incision is created, a timeout procedure is performed. All activity is suspended, music is silenced if it's on, and the surgeon reviews the timeout. All team members introduce themselves by name and discuss their role. The surgeon verbalizes who has identified the patient. We review the patient name, procedure, side of surgery, which should have been marked preoperatively. We state whether the images are needed and available, the patient's weight, whether there is a surrogate that may be required if ongoing surgery concurrent is performed. We protect the staff. We do local dosing. We also anticipate critical events and state whether images are needed. We talk about major concerns and patient disposition, whether it be to the ICU or a monitored floor bed. We talk about the use of local anesthetic and dosing. The anesthesiologist verbalizes confirmation of these discussions and talks about prophylactic antibiotics, allergy status, local regional blocks, concerns for critical events, discussing the patient's medication history, induction and airway plan. The scrub person verbalizes instruments and implants, makes sure that everything we need is present, reviews medication and solutions, make sure they are appropriately on the field and labeled. The circulator verbalizes fire risk assessment, equipment, devices, implants, blood products available if needed, and fluids for special irrigation if available, and phases of care specimens are ordered. Once this has been confirmed, we then begin the surgery. Before the patient leaves the operating room and after the surgery is over, I also always perform a debrief. This includes the circulator verbalizing instrument sponge and needle count is correct, surgeons stating intentionally retained items that need to be noted, such as a vacuum sponge or an open packed abdomen. We then verbally acknowledge the count, all specimens are identified and labeled, and then the anesthesiologist agrees on estimated blood loss. The entire team reviews any concerns for recovery, patient management, securing lines and tubes, labeling lines and tubes, discussing the management of the lines and tubes, whether a chest tube needs to be on suction or water seal, and whether bulb suctions need to be applied, how those tubes and lines will be secured to the patient. The surgeon and circulator verbalize wound class. Were there any events that needed reporting? We review the record post-op diagnosis in Epic. We complete the post-op note and talk about any Stream Connect pictures that were taken. We then talk about regulatory requirement, talking about the next level of care, and then finally a post-operative handoff protocol is performed. After the patient leaves the room, we discuss the post-operative care management team with the team that will be rounding. We review that care plan with the nurse at the bedside. We review the necessary standardized operating procedures for securing tubes and lines, for dressing changes, whether or not to narrow broad-spectrum antibiotics, organ-based PROs, anticoagulation review, think about nutrition and route, discharge planning, ERAS pathways, care pathways, knowledge management pathways, patient education, as well as whiteboard communication for the patient. We review with the family the appropriate anatomy if any rearrangement occurred, and then finally do the discharge timeout. We also employ a Blue Angel debrief. The Blue Angel debrief discusses steps of general safety, feeling statement, a safety mentality of saying, "I'll fix it," acknowledgement of all team people, using the statement, "Glad to be here," and "Oh, by the way." It's not who is right, it's what's right. It's not what happened, it's how did things happen, why did they happen, what happened, but what will we be doing differently next time? We acknowledge successes, and we acknowledge near misses. It's also important to work with your team to progress in your learning strategy. Whenever newly acquired information is brought into the operating room, it's important to make sure we have a healthy team mentality with a level, flat playing field, where good communication can occur throughout the entire conduction of the case. I, in the past, have really loved being able to refer to this Amy Edmondson article entitled "Speeding Up Team Learning," which talks about how we progress as learning a new procedure, being unconsciously incompetent, becoming a little bit more aware of the steps, which makes us more consciously incompetent, and then as we begin to acquire the skill, we become consciously competent, still thinking about each step along the way, but acknowledging what's required, doing what's required, and successfully completing the surgery. And then the ever master surgeon procedure of becoming unconsciously competent after 10,000 hours and repetition and hours of teamwork. Operational efficiency, ERAS, and care pathways are the essential elements that prevent mistakes when salvage of esophagus is performed. We developed the merit pathway using the DMAIC technique. We defined, measured, analyzed, improved, and controlled. This DMAIC quality framework gave us the aim statement of we will decrease length of stay by 10%, we will reduce complication rates by 10% without impacting staff satisfaction or cost. We set about to acquire this goal by looking at ways that we could improve our esophagectomy care patients. This is an example of the Mayo Clinic standardized clinical pathway for esophagectomy as published in the Annals of Thoracic Surgery last year. The goal here is not to show you each detail of the care pathway, but to make sure that you understand that every decision was debated heavily with the different members, and bifurcated answers were offered when two options were appropriate. We discussed the level of evidence behind each decision that was made and used this to make sure that we developed order sets, care pathway reminders, and phases of care to ensure that all members of the team were following the appropriate algorithm. We also developed a goal-directed therapy algorithm heavily utilizing the hemisphere to facilitate intraoperative management of fluids, avoiding pressors, making sure that the patient was managed in a consistent way while they were under general anesthesia during esophagectomy. We also talked about how to manage those patients during the prolonged time postoperatively, the day after surgery, 2 days after surgery, from phases 1, 2, and 3, and on. We also talked about survivorship and home recovery and standardizing those portions of the care as well. This merit pathway was able to show us that in our first year, our teams were able to reduce overall complications, atrial arrhythmias, as well as postoperative ileus. And it was through procedures and pathways like this that we were able to maintain and even improve beyond our 3-star STS database standing. So what if you accidentally damage the gastroepiploic artery during esophagectomy? This is an example of an illustration of a reverse gastric tube, whereby the gastroepiploic artery may have been damaged where you see the blue arrow in the bottom left. Instead of pedicling the gastric tube from the position of the gastroepiploic in the isoperistaltic direction, an antiperistaltic tube could be used. However, it is important to note that most of the stomach has to remain where the patient has to continue to receive blood supply from either the right gastric, the left gastric, the short gastrics, which are collateralizing to that portion of the gastroepiploic. If the short gastric arteries have been divided, this reverse tube will not work. If this is being performed for a stricture, this procedure can work. If this is being performed for cancer, it is unlikely that this procedure can be performed. When choosing a conduit, as we know, stomach is always preferred. However, sometimes a free jejunum might be good to interpose between a stomach, especially if the patient has previously had a gastric conduit that was pulled up where the gastric conduit tip became necrotic, had to be brought back down into the abdomen, and then had to have an interposition to bridge the gap between the remaining esophagus and stomach. In this next series of cases, we'll be showing you how this is performed and how to measure length. In this illustration that I had drawn many years ago, it is important to understand anatomically where different landmarks of the esophagus are located. I have drawn an estimate of how many centimeters from the incisors the length of the esophagus might be in relationship to the cervical and thoracic spine, the azygos vein, the aortic arch, the trachea and carina, all of the different stations of lymph nodes, the thyroid cartilage, the recurrent laryngeal nerve, the precarinal lymph nodes, the gastroesophageal junction, and different locations including a cervical esophagus, thoracic esophagus, and abdominal esophagus. Within the cervical esophagus, it is important to understand which types of conduits will reach. Traditionally, a gastric conduit will reach all the way up to the cervical region, but sometimes that tip of the gastric conduit is inadequate or has leaked or has become necrotic, and this requires a jejunal interposition or colon interposition to reach all the way up to the proximal esophagus or pharynx in severe cases. Jejunal interpositions can be used up at the cervical esophagus for short interposition replacement. Going farther down to the upper thoracic region of the esophagus, a gastric conduit is almost always adequate and can always reach the upper thoracic esophagus and should be anastomosed above the level of the azygos vein. When the mid-thoracic esophagus is involved, a roux jejunal conduit can sometimes reach or when stomach is brought up, it should be brought above the azygos vein. When the lower thoracic esophagus has a problem or needs removal, a jejunal conduit can frequently reach this area and frequently is much easier than pulling up stomach. And then finally, when the abdominal region or gastric conduit has to be removed, such as in the position of gastric cancer, a limb can be brought up to the terminal end of the esophagus. Again, this is definitely an estimate and should not always mandate what you do, but having these anatomic landmarks, the numbers of centimeters from the incisors, how it aligns with the thoracic and cervical spine, and having a conceptual idea of what types of conduits are appropriate for different lengths is very important when you consider alternatives for esophageal reconstruction. The Siewert classification is always important as well, whereas the esophagogastric junction is at 0, and type 2 Siewert classification is 1 centimeter above or 2 centimeters below the EG junction. Type 1 Siewert tumors are always greater than 1 centimeter above the EG junction, and type 3 Siewert classifications are always a minimum of 2 centimeters distal to the EG junction. This becomes important as tumors that are located between 2 and 5 centimeters from the EG junction require esophagectomy if you want to get at least a 5 centimeter margin. This was established a long time ago whereby the Memorial Sloan Kettering group established that a 5 centimeter margin for distal gastric tumors and mid-gastric tumors and type 3 Siewert tumors was a standard of care. However, sometimes you can hedge on the margin when the patient does not have adequate alternative conduits. Looking at type 1 Siewert tumors, almost always the choice will be for an esophagectomy and a gastric conduit for reconstruction. Type 2 EG junction Siewert classification cancers typically are treated the same as well and are classified as esophageal primary tumors that undergo esophagectomy with a 5 centimeter goal of a margin and use a gastric conduit for reconstruction. Type 3 Siewert classification tumors are characterized traditionally by the AJCC classification system as gastric cancers. The thoracic anastomosis, when performed, I typically perform an Orville anastomosis, especially when I am concerned about getting as high as possible. And here are two separate options that you can use, either bringing the Orville out through the mid portion of the esophagus where you have multiple overlaps of the circular stapled anastomosis with the linear stapled end of the esophagus, or option 2 where you bring it out towards the terminal end and you only have one layer of terminal end esophagus anastomosis that will overlap with the staple line and the Orville circular stapled EEA anastomosis. This is pictorially represented in the top left anatomic illustration. CT angio reconstruction is almost always helpful, especially when you're worried about whether or not you'll be able to use your gastric conduit. And in this circumstance, a CT angio 3D reconstruction color coding the different vessels will help you to determine whether or not you have a viable gastroepiploic artery, a good adequate jejunal arcade for jejunal reconstruction, or an adequate marginal artery for colorectal reconstruction using a colon interposition graft. This type of 3D reconstruction was very difficult to perform 10 to 20 years ago, but in today's day and age can often be performed to facilitate, especially in circumstances where the patient had surgery as an infant and the old operative report might not be available. This is a case of a patient that we recently treated at Baylor College of Medicine, whereby we were able to determine that the patient had a patent gastroepiploic artery, and these different anatomic structures are delineated here. The complicated anatomy was found due to the fact that the patient had had a prior gastric bypass surgery, and all of the anatomy was markedly destroyed and reconstructed in this CT-guided 3D reconstruction. We were able to determine that we could use stomach to reconstruct from a prior Roux-en-Y gastric bypass. It is important to note that patients who've undergone a sleeve gastric bypass, you cannot use the stomach for reconstruction in those patients and must use an alternate conduit like a colon or jejunal interposition. You can also see that the jejunal arcade branches here, delineated at the bottom below where it says common hepatic artery, are easily good targets for performing a jejunal interposition. The celiac plexus can easily be seen, where you can identify the common hepatic artery, the splenic artery, and the left gastric artery, all of which are perfectly patent. This is another way to evaluate the viability of the conduit. In this circumstance, we used ICG that was injected 3 to 6 cc's into the central venous catheter, and then used the SPY system if it's open, or pinpoint or robotic system to view in a minimally invasive approach. In this particular patient, you can see clearly the terminal end of the conduit does not get adequate blood supply. It is only the proximal half of the gastric conduit that has adequate blood supply for reconstruction. And in this case, I would not try to use this conduit for interposition. Instead, I would truncate off the terminal end and use either jejunal interposition or later use a different type of bridge, such as a free jejunal interposition, to interpose in between these two structures. This is a clear case where the terminal end 6 centimeters of the gastric conduit is completely not viable, and this patient will 100% end up with a leak due to ischemia. This is another guide to help you determine when to use specific conduits. If you have a necrotic conduit, a gastric conduit is not a great option. If you have an undilatable stricture, a gastric conduit might be the best option. If you have a cancer that extends into the esophagus and the stomach, you might be able to use half of a gastric conduit or no gastric conduit at all, in which case you may need a supercharged pedicle jejunum or a colon with or without supercharging or a free jejunal interposition. If you have dysfunctional gastric conduit or prior foregut surgery, you may be able to use portions of the stomach or may have to resort to an alternate conduit. Patients who've had a prior Whipple are frequently much more complicated, and even a supercharged pedicle jejunum might be a not so ideal option, as typically the reconstruction requires a roux for a Whipple, in which case a colon interposition is the best ideal candidate. Patients who've had a prior roux may be best suited with a colon interposition. Patients who've had damage to the gastropapillic vessels may require a supercharged pedicle jejunum or colon interposition, or a reverse gastric tube, depending on if it's cancer or not, as we discussed in the earlier slide. In patients who have inadequate length of stomach available, again, a free jejunal interposition might be the best option. And this is broken down on whether or not you have the full gastric conduit, half of the gastric conduit, or no gastric conduit. There are many indications for alternate conduits. Recurrence of the esophageal tumor after resection and reconstruction. If the patient has undergone a prior esophagectomy and develops cancer at the anastomosis or within the esophagus or within the conduit that's been pulled up, they will require frequently repeat staging, optimization, perhaps neoadjuvant therapy, and if they are an adequate conduit candidate, you may require them to have distal esophagectomy, conduit resection, proximal esophageal diversion, and then later reconstruction with a supercharged pedicle jejunum or a colon interposition. Patients who have a dead conduit are also suited for this same approach. Patients who have injury to the gastropapillic vessel that are not amenable to a reverse conduit would also require an alternate conduit such as jejunum or colon. And patients who have cancer extending into the esophagus and the stomach would require a jejunum or colon interposition. This is a patient of mine who had the dreaded dead conduit. She had a gastric conduit brought up after she presented to an original surgeon with a problem of a leiomyoma within the esophagus. The original surgeon performed resection of the leiomyoma, but she developed an uncontrolled, uncontained leak. She had florid sepsis, and when they tried to treat the leak, she continued to leak and ultimately required esophagectomy with diversion. The surgeon decided to pull up a colon interposition, but the colon interposition developed venous reflux, but the patient developed venous congestion, as can frequently be seen with colon interpositions, and this venous congestion caused the colon conduit to die. When we studied this, initially the patient had good proximal arterial inflow of the marginal artery going to the colon, but on subsequent imaging, it looks as though there was severe venous stasis and back pressure causing the conduit to die. This patient presented to me with a dead colon interposition that required resection of the dead colon conduit, proximal esophageal diversion, and then later supercharged pedicle jejunum interposition. Some patients present with a tracheo-esophageal fistula. My preferred management for these is to optimize the patient such that they can be extubated immediately, identify the area of tracheal and esophageal defect with concurrent bronchoscopy and EGD, and once the patient has been optimized, to perform a reconstruction. If the patient is not optimized, they may require a feeding tube placement or temporary stenting of the esophagus. I do not believe in dual stenting unless it is a palliative measure, because the kissing of the stents will require extension and enlargement of the fistula. When we go to approach these and perform a repair, I prefer to not resect the thoracic esophagus that's involved in the TE fistula, but rather to ablate the mucosa, leaving the muscle wall of the esophagus intact, and then to harvest an intercostal muscle flap upon entry into the chest, and to use that to patch the tracheal defect. It is important when these low thoracic tracheo-esophageal fistulas are formed to use intercostal muscle flap to patch. When these are high, you can use alternative options for patching, and this diagram in the box in the middle demonstrates how we can then close the muscle wall of the esophagus after the mucosa has been obliterated and resected over the intercostal muscle flap to hold it into position and provide another muscle layer wall for reinforcement. It's important to make sure that you remove all of the mucosa, because in some circumstances, if you leave mucosa behind, the patient can develop a mucocele, which would complicate healing and recovery. And then finally, proximal esophageal diversion is concurrently performed to allow the patient's endosophagostomy to heal, optimize the patient nutritionally, and then later perform a retrosternal anti-cardiac reconstruction with long segment supercharged pedicle jejunum reconstruction. This just shows, again, esophageal replacement options. Again, want to infer to all members that the gastric conduit is the standard of care in almost all circumstances. It's important to completely understand the blood supply to the stomach. I like to preserve the right gastric artery, leaving that large, big bundle right before I begin my staple line, or counting from the EG junction, 1, 2, 3, 4 large vessel arcades, and then stapling in between that large fourth vessel arcade before the big bundle of the right gastric, creating a 3.5 to 4 centimeter wide gastric tube, preserving the right gastroepiploic and the left gastroepiploic, dividing the left gastric and dividing the short gastrics. Again, indications, just one more time for review: recurrence of the esophageal tumor after resection, a dead conduit, or injury to the gastroepiploic vessel, or cancer extending into the esophagus and the stomach. My technique for proximal esophageal diversion has changed over the years. We have published this in the Annals of Thoracic Surgery. In the prior past, we used to divert the patient over to the side underneath the clavicle, but when we performed reconstruction, this created wound healing problems, as seen in the bottom left, where we had a T-shaped anastomosis, and those corner bridge areas of the skin didn't heal well. To avoid this, we now perform proximal esophageal diversion in line with our future incision for supercharged pedicle jejunum reconstruction. By performing the diversion in line with our future incision, we then perform an elliptical resection of the terminal end esophagostomy, giving us a linear, well-healing, much healthier approach for the incision after the reconstruction is performed. What if the esophagus is not long enough for a comfortable diversion and you know the patient needs time for a long period? In certain cases where patients have terminal disease, where you may not think they'll be a candidate for reconstruction, or where you're worried about their ability to tolerate a reconstruction, you may desire to create a more palatable proximal esophageal diversion that allows the patient to have a good fitting ostomy, a good quality of life, eating and drinking anything they want, and emptying out onto the terminal end of their conduit. The end esophagus might not be long enough to reach out for good fitting ostomy wafer, and in this circumstance, we demonstrate how a pectoralis muscle tube can be used to create a skin tube and then grafting over the skin tube to allow the patient to have a low cervical esophagostomy that's extended to a mid-thoracic cervical esophagostomy. The other advantage of this tubularization of the pectoralis muscle as a myocutaneous pedicled flap is that the shorter gastric remnant, if the patient has had in the past a necrotic gastric remnant, may later reach, and the patient may tolerate diversion for a longer period of time for optimization or adjuvant nivolumab therapy, and the esophagostomy wafer should fit better over time. The patient's quality of life should be better over time. This approach also prevents entering the area of the recurrent laryngeal nerve when the patient undergoes recurrent reconstruction. Again, if the patient has a necrotic gastric tip, by elongating the endosophagostomy, you may be more likely to use what's left of the stomach to reach up to this portion of the esophagus. So why refer the patient to a higher level of care to divert the esophagus? We have noticed that when inexperienced surgeons are performing an esophageal diversion, there is an extraordinarily high rate of recurrent laryngeal nerve damage from low-volume hospitals. This is sometimes because they do not have access to the NIMS device for recurrent laryngeal nerve monitoring, or the surgeon is simply not familiar with the location of the recurrent laryngeal nerve and accidentally damages it in the process of proximal esophageal diversion. Surgeons who rarely perform esophagostomy should more frequently be careful and wary of injuring the recurrent laryngeal nerve and really should not be performing these proximal esophageal diversions, referring patients instead immediately to surgeons who are experts in reconstruction. Some of these surgeons may rarely know how to create the optimal esophagostomy, and thus the patient has a poor quality of life while they're waiting for reconstruction. And in these circumstances, these surgeons who have an injury should reach out to complex esophageal reconstructions who are more familiar with a variety of techniques for proximal esophageal diversion, such as that we discussed with the pedicled tubularized pectoralis flap. There are many different esophageal replacement routes. There is the anterior mediastinal, the posterior mediastinal, anticolic, retrocolic, and finally subcutaneous, as is seen to the far right. The image to the far left is the anterior mediastinal route in front of the heart and behind the sternum. The route that is seen in the middle is the posterior mediastinal route. When immediate resection and reconstruction is being performed, the middle illustration is possible. When delayed reconstruction is being performed, the image to the left may be the best viable option, but also it is important to note that it frequently requires a sternoclavicular joint resection to open the area of the inlet for swallowing. When no other option is available, as a last resort, the subcutaneous option on the far right might be the best route. It is important to note that bringing the conduit through the pleura, the right or left pleura, might seem like the easiest route, but remember that the thoracic cavity has negative pressure, and conduits that are brought through the thoracic pleura exhibit negative pressure forces when they go through the thoracic route, and then positive pressure forces when they go back into the abdomen. And this may create a dynamic where poor physiology results in sump formation within the thoracic esophagus or neoesophagus, or poor emptying of the conduit. This is another front view of an anticolic to the left versus a retrocolic pathway on the right. The anticolic route may require more length of bowel versus the retrocolic pathway on the right that may require less length of bowel but requires closure of mesenteric defects. In the center view, you can see the pedicle jejunum as well as the supercharged pedicle jejunum that's delivered all the way up to the neck through an anticolic route prior to the anastomosis and prior to tunneling. When experiencing a patient who may undergo subcutaneous jejunum reconstruction, sometimes domain is an issue. In this case, we have performed a jejunal interposition that plugs into the remnant of the stomach. The stomach still has an intact left gastric artery vessel, and the remnant antrum of the stomach can be anastomosed to the distal portion of the jejunum interposition. The top portion of the jejunum has to be anastomosed to the left internal mammary artery and a transverse cervical artery, and the venous anastomosis has to go to the left internal mammary vein or to the external jugular vein. When routing this, mesenteric defects have to be closed, and in this particular case, we elected to do right-sided component separation and a vertical rectus abdominis muscle flap based on the right VRAM, rotated and pedicled to cover to create domain for the subcutaneous routed jejunum. This patient in the past had had a problem with prior cardiac surgery, a prior thoracoabdominal surgery, and prior treatment for gastroepiploic pedicled omentum to repair an esophago-aortic fistula. In this case, the patient has undergone a free jejunum interposition based on the left internal mammary artery and left internal mammary vein. We have frequently performed this procedure for patients who were later undergoing reconstruction after a necrotic gastric conduit was found. These patients who have cervical lesions within the cervical esophagus or strictures or perforations that the gastric conduit won't reach, a free jejunum interposition is ideal. Performing reconstruction with a short gastric conduit has 3 different options. Option number 1, based on the left, is a mammary-based free jejunal interposition. Option number 2 is in the central, and that is gastroepiploic-based free jejunal interposition. This gastroepiploic-based free jejunal interposition might need to be matured in the abdomen and then later brought up to avoid some complications. And then finally, the most complicated, which is a bipedical delayed jejunal interposition, whereby the top portion of the jejunum is based off of a free flap where it is anastomosed to the left internal mammary artery and vein, and the lower portion of the jejunal pedicle is connected to the gastroepiploic artery and vein. Initially, the plan for this patient and several more was for the entire jejunal arcade to be as the one in the middle, where it was based off of the gastroepiploic, but it would not unfurl enough and it was too redundant. And in order to unfurl it and allow it to reach the proximal esophagus, we had to cut the mesentery and then subsequently anastomose it to the left internal mammary artery and vein. As you can see in the red arrows, each of the vascular pedicles are highlighted. This is an image of the patient to the left where we could not unfurl the jejunal interposition, and the image on the right in the central area, you can see where we're preparing the anastomosis and the jejunum has been anastomosed to the stomach, and the mesenteric artery and vein are being prepared to be anastomosed to the gastroepiploic artery and vein. The artery and vein are highlighted in the image to the left, where you have only half of a gastric conduit and an extended length of small bowel. In the central image, you can see the gastroepiploic source that's been anastomosed and the gastric conduit. And then to the far right, you can see the half of the gastric conduit with the anastomosis intact. Subsequent reconstruction with the left internal mammary artery and vein for the superior arcade of the jejunum is seen in the middle top image, as well as unfurling of the bowel and tunneling and internal Doppler monitoring. The anastomosis of the artery and vein to the epiploic artery and vein from the mesentery to epiploic was treated with a Cook-Schwarz internal Doppler that was later removed after the healing took place. Subsequently, you can see our inability to unfurl the jejunum after it was brought up, and by dividing the bowel, the jejunum was able to be straightened but became markedly ischemic, as we would expect when you divide the mesentery, and that small portion of the artery and vein of the mesentery was subsequently anastomosed to the left internal mammary artery and vein at the level of the SC joint resection. This successfully recreated GI continuity in multiple cases. And here is the final result, where skin grafting was used to cover that portion of the small bowel. The patient had a mediastinal trach on this particular case. Cook-Schwarz external Doppler monitoring of the arterial and venous anastomoses was performed, with delayed transposition of the bowel up after the gastroepiploic artery and vein anastomoses had healed. Again, you can see the swallow in this patient in the top central figure, as well as the result after a skin graft had been used to cover the region. Our next area of topic will be free jejunal interposition. Cervical jejunal interposition is ideal whenever you have a situation where you have an isolated short segment of cervical esophageal reconstruction that's necessary, and the vessels that supply this are mesenteric anastomosis to left internal mammary artery or vein, or transverse cervical artery with external jugular vein. This is a free jejunal interposition that was performed to isolate a resection of the cervical esophagus where a single-site squamous cell esophageal tumor at the level of T1, T2 was identified. This was a very difficult distal anastomosis and sometimes can be performed with a thoracic distal jejunal anastomosis, and at other times can be performed from a large collar incision with flexion of the head to deliver that distal portion of the esophagus above the level of the thoracic inlet. This particular patient had undergone definitive chemoradiation. There was a concern of the viability of the esophagus for anastomosis after radiation. However, they successfully underwent free jejunal interposition for discrete residual disease that was found. Free jejunum is also performed to interpose between terminal esophagus and a colon interposition when a patient may have had a necrotic distal tip of the, or proximal, a necrotic proximal extent of the colon interposition. In this particular case, the patient had a colon interposition performed and the proximal extent of the colon became necrotic, and the patient had a Mallinckrodt tube placed inside the terminal end of the colon, brought up out of the mediastinum. The patient had GI discontinuity, and in order to bridge the gap, a free jejunal interposition was performed. At the time of consultation, I performed an illustration of the pertinent anatomy, which can be seen in black and white to the right. This is another patient that presented with an Amplatzer stent that was placed within the esophagus. The patient required head of clavicle resection and SC joint resection to open the thoracic inlet, but had a redundant conduit interposition and required esophageal colonic revision of a stenotic anastomosis. This was treated also with a free jejunal interposition, as is illustrated in the central figure, and the original presentation that I drew during the consultation can be seen in the image to the far right. Next, we'll talk about pedicled jejunum. Pedicled jejunum is ideal for vagal-sparing esophagectomies, short distal segmental resections, a roux after gastrectomy. However, it's important to note that only vagal-sparing interpositions can be performed. Commonly, this is referred to as a Marandino procedure for patients who have gastrointestinal stromal cell tumors, extensive leiomyomas that require resection of the esophagus, although this is rarely indicated. It's very rare that the patient can be treated with a very small, isolated resection of the esophagus that does not require thoracic lymphadenectomy. In this case, the jejunum interposition or pedicled jejunum is supplied by the superior mesenteric artery jejunal branches as a pedicled flap. This is a roux that was performed to replace the esophagogastric junction in a patient who presented with a prior Links procedure. The patient subsequently was allergic to metal after extensive metal testing and developed an undilatable stricture. Repetitive attempts to remove the Links were unsuccessful because the patient continued to present with what appeared to be ischemic or profuse granulation tissue at the EG junction, and thus resection of the EG junction was required, and a roux limb was brought up to the area of the terminal esophagus when a G-tube was used to go into the remnant stomach. We elected to keep the stomach and not perform esophagectomy as the entire thoracic length of the esophagus was viable, and brought up a roux anticolic and anastomosed it with a 25 EEA circular staple to the terminal end of the esophagus in a very similar fashion as what we would do for gastric bypass. This patient did quite well after. The Marandino procedure or vagal-sparing esophagectomy has the advantage of keeping the vagus nerve intact. This may result in potentially less dumping, but is not a good situation when the patients have an esophageal cancer and a lymphadenectomy is required. This is perhaps best for gastrointestinal stromal cell tumors. The jejunum is interposition and pedicled. It is a very difficult surgery to perform and requires three anastomoses, where the jejunum interposition, proximal esophago-jejunal anastomosis, distal jejuno-gastric anastomosis, and then side-to-side, stapled side-to-side, functional end-to-end jejuno-jejunostomy anastomosis is performed. Our next option is long segment supercharged pedicled jejunum. I've given several videos on this. You may want to refer to the supercharged pedicled jejunum video that's on my YouTube channel. However, I will give a brief overview here. The conditions that require long segment supercharged pedicled jejunum absolutely are when you've lost the gastric conduit and colon conduit. When you've only lost the gastric conduit and colon is an option, I believe you should use the conduit that you're most comfortable facilitating. In my particular experience, I am more comfortable with the jejunum, and I think it has additional advantages. The supercharged long segment pedicled jejunum has a proximal free jejunum mesentery anastomosis of the left internal mammary artery and vein to the cervical to the mesenteric artery and vein, respectively, a proximal esophageal cervico-jejunal anastomosis, and a more distal jejunal anastomosis if a roux limb is used. The inferior mesenteric artery supplies the inferior arcades of the jejunum in this circumstance. SPJ stands for supercharged pedicled jejunum interposition. This is best in patients who have a gastric conduit that is not possible for use, and SPJ has the advantages of not requiring formal preparation like a colon may, is usually free of intrinsic disease, has a similar diameter to the esophagus, has intrinsic segmental peristalsis, unlike a colon that will not have any peristalsis after transposition, as we have demonstrated with manometric studies. It may not undergo senescent lengthening, such as the colon frequently can. And we see this 3-to-1 length ratio with a small bowel that can be performed with a roux limb, but becomes prohibitive for bringing it all the way up to the cervical area. Thus, in order to unfurl the jejunum, we have to perform the microvascular augmentation and split the mesentery all the way, as you see in this image in the central figure. Adequate length can be obtained to replace the entire esophagus with jejunum when a cervical microvascular augmentation is performed as part of the reconstruction. Otherwise, a roux will only reach to the mid-thoracic esophagus. This is a review of the literature that we performed. Dr. Pujagar and I looked at all of the review of the literature, including 290 patients. The majority of route was retrosternal. The patients had anywhere from a 1 to 11% mortality and a 0 to 36% leak rate and a 0 to 11% graft loss. There are 20 steps to performing a long segment supercharged pedicle jejunum. The original step is positioning and prepping the patient from the neck all the way down to the thighs in the event that saphenous vein has to be harvested. It is extremely rare that saphenous vein has to be harvested, but we have found that prepping this into the field is always a good idea. The incisions include a thoracic and cervical incision, taking out the terminal end esophagostomy, as well as abdominal incision. Abdominal exploration for metastatic disease, along with a pre-operative evaluation that's extensive to optimize nutrition and rule out any expected abdominal disease, is always performed. Bowel transillumination, followed by concurrent neck dissection, left internal mammary artery and vein prep, creating the tunnel for the conduit, selecting the appropriate jejunal route, testing the blood flow, and ligation of the third arcade is all performed with the surgeon, both abdominal surgeon as well as plastic surgeon. In my case, I perform almost all of the thoracic portion, all of the abdominal portion, and some of the cervical portion. We then deliver the jejunum into the anterior mediastinal or retrosternal route. We then perform microscopic venous and arterial anastomosis. We resect the redundant bowel. We create the bowel neck anastomosis. Today, we're creating the bowel neck anastomosis of the esophagus to the jejunum prior to arterial and venous microanastomosis. We then insert the monitoring device, place drains, close the neck, create the roux, place a feeding jejunostomy, close the mesenteric defects, close the diaphragm defect, and perform abdominal wound closure. This is a prior patient of mine who had undergone a sleeve gastric bypass surgery for a clinical ultrasound-guided T3N1M0 esophageal adenocarcinoma. The patient underwent neoadjuvant chemoradiation therapy through the cross regimen and then underwent resection. The patient, because of their prior sleeve resection, required resection and supercharged pedicle jejunum reconstruction. The anatomy of the patient can easily be seen in the image to the left that I drew after the surgery. This is a patient who presented with extensive tumor spanning 10 centimeters of the esophagus and 6 centimeters into the stomach, requiring esophagectomy and gastrectomy. The patient underwent esophagectomy with proximal esophageal diversion. We gave adjuvant nivolumab therapy, gave the patient 6 months to recover, and then performed a delayed supercharged pedicle jejunum, as can be seen in the illustration to the left. The illustration to the very far left shows clearly the original illustration that I gave for the patient, showing the extent of tumor and the original staging, which was after neoadjuvant treatment, a YPT3N0M0, with 41 lymph nodes removed and taken during the procedure. This is another example of a patient who underwent long segment supercharged pedicle jejunum. However, this patient was referred to me from Colorado. He had a prior esophageal conduit necrosis that resulted in fistula to the bronchus intermedius on the right that was repaired with an intercostal muscle flap through a right posterolateral thoracotomy. I performed a left posterolateral thoracotomy and repaired an airway injury on the left, and then had to do a median sternotomy to repair an injury of the central carina that had a remaining injury to it, and this surgery had to be performed on ECMO. After all three of the tracheal injuries had been repaired, the patient had proximal esophageal diversion and then later underwent supercharged pedicle jejunum reconstruction. This was performed successfully, and the patient continues to do well living in Colorado even today, eating things such as even a fajita. This is an illustration of the supercharged pedicle jejunum for a patient who had a defect after unsuccessful gastric conduit reconstruction. And this is a reference for the websites and a QR video showing 1 hour long video detailing how we perform long segment pedicle jejunum in my experience from when I was at Mayo Clinic, and my surgery detailed with description and narration, combined surgery with Dr. Samir Mardini. With Chase Sims, Anita Mohan, and multiple other teams, we were able to publish our complex esophageal reconstruction pathway and checklist. We summarized with a root cause analysis every time a problem occurred after a supercharged pedicle jejunum, and we have clearly delineated our care process measure with that pathway for reference. For the sake of time, I won't go through this in detail, but this is published in the Annals of Thoracic Surgery from 2023 and is available for review. Some of the modifications from when I left Houston Methodist Hospital and went on to Mayo Clinic included that we separated the resection from the reconstruction in almost all cases. We went to using only a Cook-Schwartz Doppler probe on the vein rather than exteriorizing the bowel. We used a small bowel window for visualization rather than exteriorizing the bowel. And today we are now completely closing the area and using a Doppler probe. We perform esophagojejunal anastomosis before we do our microvascular work. We 70% of the time will perform a hand-sewn anastomosis or perform a circular stapled or linear stapled anastomosis depending on time. We perform an anticolic route and retrosternal route and roux of jejunum in most cases. We have a standardized pathway that we follow. Our mean length of stay is 19 days, and we were able to reduce it to 11 days after these modifications were performed. And we had a 0% 30-day and 90-day mortality rate, which remains today. This is an example of the bowel transillumination that helps us to identify the first, second, third, and fourth jejunal arcades. Typically, we preserve the first 20 centimeters of small bowel after the ligament of Treitz and preserve the first jejunal arcade in situ, and then divide the bowel wall and divide the mesentery all the way up to the superior mesenteric artery between the first and second arcade, using the second arcade that will be transposed up to the left internal mammary artery and vein. This standardized process is published in the Annals of Thoracic Surgery and clearly demonstrates the arcade vessels where we use the second arcade that will be transposed and delivered to the left internal mammary and artery for microvascular anastomosis. We also preserve a bit of the fat from the extra portion after we remove redundant bowel at the proximal esophageal jejunal anastomosis to unfurl the bowel and straighten it out. Almost always we end up resecting some of the redundant small bowel so that it's a straight anastomosis. However, that remaining fat of the mesentery, just proximal to the second branch, is used to lay over the anastomosis and buttress it as a pedicled flap. We then also will use the third branch as a bridging arcade And sometimes we'll even use the fourth branch as additional bridging arcade when additional length is required. Once this is performed, we completely divide between the second and third arcade to allow unfurling of the small bowel. If this unfurling, as you can see on the images to the left before unfurling, and then to the image B after unfurling, you can see how much additional length and how much more straight the bowel becomes. In the image to the right, the traditional unfurling occurs between the second and third arcade. However, sometimes we decide to unfurl between the third and fourth arcade, and these different scenarios are seen in the image central figure to the right. The right bottom figure demonstrates how the same approach can be used where the unfurling occurs between the third and fourth arcade, but the fourth is also used as a bridging arcade to provide additional length. Jejunal testing and ligation is always performed. The transillumination of the bowel can easily be seen in the images to the left, whereby we are using a traditional approach from the arcade separation as is seen in the top right. This is that same illustration of the traditional arcade that was seen in the top right image, whereby the second mesenteric branch will be anastomosed and the arrow to the left internal mammary artery and vein. The arrow in the middle delineates how we divide the mesentery all the way up to the bowel wall, and the arrow to the right shows that bridging third branch of the superior mesenteric artery and vein that is left as a bridging and connected to the fourth branch, whereby it is a pedicled portion of the jejunum. This is as it is unfurled and laid out in front of the sternum before we create the retrosternal route and transposition, placing it into an endocatch bag and pulling it and pushing it into position. This is the arcade unfurled completely with posterior transillumination. And this is again another image whereby the third arcade is used as a pedicle and the second arcade will be microvascularly anastomosed to the left internal mammary artery and vein. This shows the microvascular augmentation. We have to dissect the left internal mammary artery and vein. It is prepared by clipping it distally and transecting it with an Acklin clamp more proximal. After the left internal mammary artery is prepared, we then will prepare the vein. Here you can see a microscopic venous anastomosis is performed using typically a 3.5 millimeter venous coupler, whereby the vein is brought into the central portion of the coupler and then is splayed out on the prongs and exteriorized, flapping it over the prongs to put it into final position. The microscopic arterial anastomosis can then be seen, and this anastomosis is performed using an interrupted 9-0 or 10-0 nylon suture under the operating microscope. Different images of these anastomoses can easily be seen in the central image below these, but the venous anastomosis is typically performed first, followed by the arterial anastomosis, and the Acklin clamps are removed only after blood supply is restored. A Doppler is used to measure the blood flow on the vein and the artery, and size match is important. On the image to the left, you can see the venous coupler being closed, making sure that there is no misalignment or malalignment or twisting of the vessels prior to closure. Now, today, we place a marker on the line of the vein before transection to prevent it from twisting or being malpositioned. This is an iterative analysis of problems that lead to solutions. Table 1 on the far right is published in the Annals of Thoracic Surgery and shows all of the issues that we were able to identify and targeted modifications for a revised intraoperative algorithm that have led to continuously improved outcomes. Monitoring, typically we use an external bowel indicator in the early series, as is seen in the bottom left image, but we've now transitioned to a Cook-Schwarz Doppler only. In the interim portion, we had left a small skin window, as can be seen in the bottom right image, but now today we are completely closing the wound to prevent infection or contamination and to lower our leak rate. Again, you can see the pertinent anatomy with the left external jugular vein, the left internal jugular vein, left common carotid artery, vertebral artery, transverse cervical artery, suprascapular artery, thyrocervical trunk, left subclavian artery, and left internal thoracic artery and vein, all of which can be used as sources of inflow or outflow depending on your need. Anita Mohan and Samir Mardini participated in evaluating the quality of life after patients underwent standardized protocols for supercharged pedicle jejunum reconstruction of the esophagus, and we demonstrated that the average upper digestive disease app scores represented by functional outcomes less than 12 months post-surgery were markedly improved more than 12 months after surgery, but were not statistically significantly different. Now discussing colon interposition. Typically this is used as a second choice when stomach is not available and is based off the marginal artery of Drummond and can supercharge colon as well. The supercharged free colon interposition is also another option where it is not pedicled, or it can be pedicled and supercharged. You can do a free colon interposition or a supercharged colon interposition. In this particular case, we aimed to do a supercharged colon interposition, but the artery that was pedicled was not viable, and we had to do a free colon interposition. This is for a woman who presented from Minneapolis with a locally advanced esophageal gastric cancer. She underwent a reconstruction, developed a leak, was salvaged with a stent, but the stent eroded into the colon. The colon was stented, and the two stents were kissing. She subsequently underwent massive resection of a segment of the transverse colon, the remaining portion of the roux, the distal remaining esophagus with proximal esophageal diversion, and then later underwent supercharged colon interposition attempt, but this was not successful, and we had to do a free colon interposition. Again, this is delineating the patient who had a free colon interposition to the far right. We can also perform long segment esophageal replacement options with supercharged colon. Ken Kessler and his team from Indianapolis have more experience with this, and I would refer to their publications for this type of guidance. Colon interpositions can be based off of the left colon, the right colon, and in this particular illustration to the far right, you can see where the intestine is everted into the stomach to prevent sort of a reflux scenario and provide some portion of like a fundoplication or anti-reflux valve as the colon is dunked into the stomach for the cologastric anastomosis. Again, supercharged or free colon interposition, as described by Ken Kessler's team, has been successfully performed in many institutions. It is important to note that whenever a free colon interposition is being performed, a long marginal artery must be preserved. And finally, for those patients who are not a candidate for any of the aforementioned procedures, sometimes a myocutaneous flap is required. Typically, the condition that requires these is a tiny segment of cervical esophagus requiring revision or patch, or a last choice when no other options are available. The sources of these are a variety of different sources, but typically the source can be an ALT, anterolateral thigh flap, or a radial artery vein pedicled flap, or a pedicled rotated myocutaneous flap, such as a vessel like the latissimus. This is a patient of mine who presented with an esophageal stricture after a gastric conduit was brought up to the terminal end of the esophagus. It was an undilatable stricture. We performed a free forearm flap and used a paddle of the skin to augment the stricture, as can be seen in the bottom right, and then used a paddle of the skin that was exteriorized as a monitoring flap. The small proline suture in the center of the monitoring flap was where the Doppler probe should be placed for monitoring. Alternatively, a skin tube can be used for reconstruction, or a larger paddle can be used, but in thin patients, this will provide some significant wound healing problems on the forearm when a larger portion of skin is removed. Looking at other myocutaneous flaps, this particular patient had a bridge that needed to be gapped, a gap that needed to be bridged between the terminal end of the esophagus and a supercharged pedicled jejunum. We created an AV loop, what we call the BYOB, or bring your own blood supply flap, that was a saphenous vein harvested from the leg, brought up to the right axillary artery and vein as an AV loop, and then a myocutaneous flap of the right latissimus muscle with skin folded in the shape of a skin tube and anastomosed proximally to the esophagus and distally to the jejunum, then gave the patient during endoscopy the anatomy of esophageal lumen, myocutaneous skin tube, which we called the hairy esophagus, jejunum, and then extending down more distally into the bowel. This is an illustration of the BYOB graft that has been accepted for publication in the Annals of Thoracic Surgery. This myocutaneous free flap is interior of the esophagus, a skin tube going into fat, going into muscle that can be brought as a whole block for the free flap, that the artery and vein of the free flap are then tied into the saphenous vein that previously was allowed to mature after it was brought out as a loop graft off of the axillary artery and vein. The terminal end of the loop graft was divided to provide arterial inflow and venous outflow. Again, the ALT thigh flap can be used to transpose and replace a tubularized portion of the esophagus or to patch a strictured portion of the esophagus. It is important to note that adequate cervical wide exposure is frequently required. Synthetic esophageal replacement is long been investigated. Our group at Mayo Clinic had looked at clinical grade tissue engineered esophageal graft that could be used for segmental esophageal reconstruction in a human patient based on compassionate use. The graft was able to support regeneration of the esophageal conduit, and histologic analysis of the tissue post-mortem 7.5 months after the implantation revealed complete luminal epithelialization and partial esophageal tissue regeneration. Although the patient expired at 7.5 months, this did prove concept and was used under compassionate FDA granted permission. This is an illustration of that technique, whereby temporary stenting of the biologic mesh allowed for wound healing while new tissue grows over the scaffolding. You can see in the image to the far left the tissue interposition. In the image to the center, you can see the endografting or stenting of the esophagus to protect the area while it's healing. And then in the image to the far right, the impregnated exosomes to augment healing that were part of a porcine pig lab for unpublished data that was funded by the Shannon Foundation, looking at Rion Pharmaceuticals that developed out of the regenerative medicine program at Mayo Clinic and the Bafar lab for the product that is now called Plated, used topically for cosmetic purposes, and is an exosome that has the properties to enhance healing, made by Rion Pharmaceuticals. Reoperative intervention is frequently required in some of these cases. In this particular case, the patient had gastric bypass, but had a remnant portion of the stomach that was left that was viable. However, in some cases where a gastric bypass has been performed as a roux gastric bypass, there's a small gastric pouch, and the patient can develop cancer in the remnant of the gastric pouch. The one good thing about this is that it prevents distal progression and cancer spread to the remaining portion of the stomach that has already been tubularized and ischemically preconditioned. It is important to note that patients who have undergone a prior gastric bypass can have the gastric conduit used for reconstruction. In some cases, however, such as the case that was given to me as a referral, the patient instead had a colon interposition pulled up, and this colon interposition died. I therefore used what was left of the stomach from the gastric bypass as a conduit with a free jejunal interposition to bridge the gap between esophagus and stomach. There are some special circumstances whereby the patient may develop a tracheo-esophageal fistula, an esophago-atrial fistula, or an esophago-aortic fistula, and I will briefly review our approach for these. This is a patient who developed a tracheo-esophageal fistula. The fistula can be seen in the endoscopy to the right, and the swallow can be seen to the left. This patient was referred to me with a mid-thoracic tracheal fistula. We elected to perform reconstruction of this using a pedicled right pectoralis muscle flap that was brought down and used to reconstruct the posterior membranous portion of the trachea. Alternatively, an intercostal muscle flap can be used, or other muscle flaps with myocutaneous approach can be used. This is a repair of the tracheal defect with pectoralis flap off the thoracoacromial artery. The illustration of this technique is seen to the right, and this is, again, a pectoralis reconstruction of the trachea. This is a long tracheal segment that was injured during an accidental intubation, and this was approached from a right thoracotomy. And in this particular case, we elected to repair with intercostal muscle flap. This was not a fistula to the esophagus, but instead a long tracheal injury. However, very careful approaches have to be taken to prevent erosion, and in some of these cases I have seen where this erodes into the esophagus, in which case we open the esophagus, ablate the esophageal mucosa or resect it. Sometimes argon plasma coagulation is required, and then the flap can be used to interpose and repair the airway. The proximal esophageal diversion has to be performed, and subsequent later reconstruction after the patient has been optimized. Typically, this is performed on ECMO, but in some cases, isolated small catheter intubation of the right and left mainstem can be performed. In this case, we used a long armored tube that went into the right side and was anchored to the teeth, and we used a small left-sided tube that went through a prior tracheostomy and allowed us to ventilate the patient during surgery, during the tracheal repair, isolating the area of the injury without putting the balloon from the ET tubes up where the injury was, and isolating the balloon into the more distal primary mainstem bronchi. This is a 3D reconstruction of a tracheoesophageal fistula. whereby you can see the connection between the two lumens. And here you can see an injury to the airway. When you look at the side of the airway that was approached through a right thoracotomy, again using the same position of opening the esophagus by transecting it proximally and distally, diverting it proximally, and bringing the distal portion, resecting and stapling across the EG junction, salvaging the stomach for later reconstruction, and then repairing the tracheo-esophageal defect of the trachea or main stem bronchus with an intercostal muscle flap, ablating the esophageal mucosa, and then closing the muscle over. This is again an esophagobronchial fistula with again a similar approach showing the proximal esophageal diversion. The defect can be seen in the esophagram to the top left. The stent can be seen in the top right. The fistula closure can be seen on CT before repair and on the right after repair. When a long segment of esophagus has been injured or a long segment of trachea has been injured and an interposition is being performed, 2 muscle flaps can be used to bridge the gap, as can be seen in this illustration. Esophago-atrial fistulas require underwater endoscopy. If gas or air is used, massive embolization occurs. This underwater endoscopy demonstrates the area of the esophago-atrial fistula, and we have published in multiple cases video content of how to approach this with a minimally invasive approach. In this particular case, you can see the fistula to the left, whereby a small amount of blood is seen to be coming out of the esophago-atrial fistula. This is most commonly seen after the patient has undergone a prior left atrial ablation for arrhythmia. The location anatomically is seen in the central figure in the top middle, and pathologic evaluation post-mortem is seen in the 2 images in the top middle, and the surgical approach can be seen in the video to the right. In this particular case, we have groin lines in, we're ready to go on bypass, but however, we were successfully able to repair the esophagus by performing isolation using Kittners to dissect the esophagus off of the left atrium, and then performing a clamping maneuver to isolate the left atrium and prevent bleeding. We used a combination of blunt and sharp dissection, and were able to successfully evaluate this area. Please see the separate video of the esophago-atrial fistula repair. For the sake of time, I will not show this entire video. And even more difficult to treat, endovascular exclusion has been described for patients with this new issue of esophago-aortic fistulas. Esophago-aortic fistulas have been treated in the past with endovascular exclusion for the bleeding vessel going into the esophagus. In this particular instance, you can see the stent in the esophagus and the aorta. You can see that the aorta could be excised as one option with a homograph interposition and omentum covering that can, after a period of healing, be replaced with stenting, or excise the esophagus and divert and then reconstruct the esophagus at a later time with a substernal conduit and put in a rifampin-soaked gauze, a rifampin-soaked graft. There are a multitude of different options. When you do deploy a stent for an esophago-aortic fistula, it is forever infected until it's been removed. This is just showing some of these techniques that have been performed for exclusion for esophago-aortic fistula, which is commonly used with aortic stenting. Typically, when patients develop any type of complicated problem within the esophagus, whether it's a fistula, a defect, a stricture, or cancer, or complicated reconstruction, I always follow the same process. I perform a good history and physical. I perform a primary assessment. I acquire all the old operative reports and images, and I always optimize the patient first. I draw the anatomy as I understand it. I draw check boxes of all of the studies that need to be performed, and then I draw a pathway of what I aim to do, what I expect the treatment to be, how I expect the patient to recover, and what steps are required for subsequent staging or evaluation or optimization prior to complex reconstruction. I always draw out the survivorship care plan, giving the patient the knowledge that I will rarely present them as the diagnosis of cure until they are 5 years out from their cancer. My job is to get these patients from the top of the page to the bottom of the page, and I aim to do that with constant attention to detail, preoperative surgical optimization, nutritional optimization, frequently with good feeding tube access, and a comfortable proximal esophageal diversion such that they are not in a rush to get reconstructed. Historically, there was a club called the Esophagus Club. It was an annual award of distinction for the surgeon who suffered the most amount of pain when they were trying to treat a patient with a complex esophageal problem. I was honored with this award, and many other prior surgeons who've dedicated their lives to the treatment of patients with complex esophageal disease have been awarded with this distinct honor. I would just like to emphasize that managing patients with complex esophageal disease is very frequently, it feels like this image where the esophagus is tied into a knot. These patients require lifetime longitudinal care, not isolated segmental care. The teams that support us and help us to work up these patients, plan their complex surgery, organize the multidisciplinary teams that do the repair, often are exhausted with all of the details, and frequently the compensation is not adequate financially. This means that the desire to fix these patients has to come from the inside. The teams have to be dedicated. They have to understand the need, and everyone on the team has to buy into the philosophy, the goal, and the complexity required to treat these patients. I've developed the patient-reported outcome measure digital electronic PRO monitoring system called the Upper Digestive Disease App. This was co-developed with Mayo Clinic and evaluates the patient on 12 variables after foregut reconstruction or any prior foregut surgery. Patients may suffer with dumping, pain, reflux, heartburn, regurgitation, weight loss, or fatigue, declining physical overall health, declining overall mental health, or any symptom pertinent to the care of that disease. We looked at focus groups to identify what patients suffered from, and we looked at things that patients volunteered that they cared about most after these surgeries, and we made sure that we carefully measured each of these things by creating a patient-centered dashboard telling them where their score is and how that compares to the scores of other like patients and where experts think they should be, categorizing their numerical score on a continuum, putting them into a color-coded group: green for good, yellow for moderate, and red for poor, and helping them to understand when they need to get education or modify or go for help. We then developed the Mayo Clinic's first completely virtual clinic, Mayo Clinic's first decentralized clinical trial, and a survivorship care plan based on Ask Mayo expert care pathways that are curated for patients with each problem of the 12 variables after foregut surgery when they scored in the red zone and indicated that they had a severe problem. It's important to note that surgery is only half of the journey, and the other half of the journey is caring for these patients longitudinally, as we have published in the Journal of Thoracic Disease in 2023, delineating how we built the virtual clinic, the Ask Mayo expert care pathways, and facilitated self-care. This digital health e-monitoring virtual clinic is one of the world's most novel programs helping patients to get standardized care remotely. Some pearls from what I've learned throughout my 20-year career. Long segment esophageal reconstruction can be accomplished with a variety of different techniques. Always salvage the stomach when you can. Use all of your tools, even if it is a reverse conduit. Meticulous attention to detail and care pathways can drive improved outcomes. A multidisciplinary and systematic approach with standardization is needed to assist patients for perioperative optimization, execution of the procedure, and reduction of errors. It is an iterative process. A jejunal interposition is ideal for long segment esophageal replacement. A delayed reconstruction can provide time for surgical and medical optimization, drop the risk of prolonged anesthesia and hemodynamic instability, and enhance the delivery of adjuvant therapy. In spite of improving outcomes, the incidence of surgical and medical complications are still significant in this complex jejunum interposition patient group. Digital PRO data, patient-centric PRO data, may provide an avenue to compare interventions and monitor symptoms and choose the best conduit, enhancing understanding of the long-term postoperative course and assisting in targeting persisting symptoms. ePRO data may also overall help us to facilitate improving the overall quality of life in these patients. How do you eat an elephant? Bite by bite. Thank you to all of our teams that help us to provide extraordinary care. I would like to call attention to my teams that supported me at Houston Methodist Hospital, at Mayo Clinic Hospital, and now at Baylor College of Medicine. We would be nothing without the team. I'd like to thank my current colleagues, Sean Groth, Taylor Ripley, Ramiro Fernandez, and the artful, skillful, incredible surgeons, Dr. Eddie Liu and Dr. Andrew Wang, who work with us today doing complex esophageal reconstruction. I would also like to acknowledge Dr. Samir Mardini, Pierre Chevre, Mike Klebeck, and all of the other multiple teams that have worked with me in the past. The Baylor College of Medicine Lung Institute is Houston Medicine. Patients come with problems and leave with solutions. I'd like to invite you to follow us at BCMLUNGINST and scan this QR code to learn more about our program. Thank you again to all of my colleagues that work in the clinic, Subin, Tanya, and Priya. For those that work in the postoperative care setting, Kate and Sarah, and my co-surgeons, Dr. Sean Groth, Dr. Ramiro Fernandez, and Dr. Taylor Ripley. Thank you. And especially thank you to my entire Department of Surgery, the 250 surgeons who work within the Michael E. DeBakey Department of Surgery, combining the Texas Heart Institute, the Baylor College of Medicine program, as well as the multiple hospitals where we go. Thank you to my former program director, Dr. Joseph Caselli. Thank you to Dr. Matt Wall, and especially thank you to Dr. Todd Rosengart, my chair. This is the YouTube channel. @Shanda Blackman is my Twitter handle, and I'd invite you to please follow the other videos that we curate to specifically meet your needs, to learn as much as you can about thoracic surgery. Thank you again, and here's my contact information.